today's topic is really timely. It should be a great presentation, one that a lot of people can really relate to, whether you are a caretaker for a child, you're concerned about your own personal health. And this conversation, I think, really weighs heavily on the public psyche these days, particularly in the aftermath of, even more so in the aftermath of COVID. And I'm really thrilled that we have an expert here in behavioral psychology, Dr. Gretchen Chapman, professor and department head of social decision sciences. And I'm glad that we have you here, but also really grateful for your leadership in the Institute and your role in our projects as well. And in addition to a number of accomplishments, she's also an avid AI-SDM seminar attendee. So thank you so much for coming and participating, and I'll turn it over to you now.
Thanks, Sean.
You have your
Is there a way that you can take the control bar
yeah.
off? I would do that here, but I don't.
Yep, I got it.
All right, good afternoon, everybody. Thanks for being here. I know it's the last day of classes and it's 70 degrees and sunny outside, so I really can't imagine why you're here. There is a very elite, select group of audience members here in the room with a very large box of cookies, and thanks folks who are on Zoom too. So I'm going to tell you about some of my work on vaccination behavior and try to convince you of why it's an interesting thing to study. Vaccine hesitancy is one of the top 10 threats to global health, according to the World Health Organization. And I've been studying vaccination for a really long time, long before it was fashionable. And I'll try to explain why I've stuck with it for so long. There are some important applied reasons. It's an important preventive behavior. It has big policy relevance. Also, as health behaviors go, it's kind of easy to study because it applies to everyone. Like everyone has some vaccines they're supposed to get sometime. For some vaccines, like the flu shot, it's an annual behavior. So every single year, there's another opportunity to do another study. And sometimes we have the opportunity to get objective measurement, like a health record measure of whether someone has been vaccinated as opposed to just self-report, which is harder to do for some other kinds of health behaviors. There's also a bunch of theoretical reasons to study vaccination because it encapsulates a lot of characteristics of decisions that are interesting to decision researchers. Like there's the risk and uncertainty angle that, you think about what's your risk of getting infected and how much is that reduced if you get vaccinated. That risk idea is a particularly numerical concept, which is not easy for all lay people. I'm going to show you some experiments about that today. There's the idea of delayed consequences, that you get vaccinated now to protect you from an infection you might get later. There's the externalities, where if I vaccinate, I'm not just protecting me, I'm protecting you all. So how do those social preferences come in? It becomes a very social behavior. And like any other behavior that we care about, it's an opportunity to look at some choice architecture. How do we structure the environment to make the healthy choice the easy thing to do? So my overarching research question is, how can we harness what we know about behavioral science to facilitate vaccine uptake? A number of years ago, I had the opportunity to work with a wonderful team of co-authors on a big review paper on the psychology of vaccination. And coming out of that paper was this increasing vaccination model that the WHO adopted. And you can see that there's kind of multiple buckets of psychological factors that influence vaccination. So in the upper left, we have the sort of cognitive attitude bucket of what people think and feel. Then in the lower left, we've got the social processes, like how they're interacting with others, what other people are doing. And then that blue box in the middle are the practical factors, the things that we do that just to try to change behavior and not try to change what people believe. So I'm going to give you an example study from each of these boxes to kind of give you a flavor for different approaches here. So first, we'll start with what people think and feel. One important message from behavioral science is that the way you present information can be very important above and beyond the actual content of that information. I'll tell you about a study I did with Alison Buttenheim on ownership language. This study was part of a big mega study conducted by the Behavior Change for Good initiative at the University of Pennsylvania. They had 20 different text message content for text messages that they sent out to patients. These were patients who already had a doctor's appointment scheduled. They got the text message the day before their doctor's appointment, and then the team had access to the electronic health records to see, did the patient get vaccinated at that doctor's office. So a whole bunch of research teams contributed to this mega study. There was a paper about the entire mega study, and this is the main graph of it showing all the different text message arms and how they compare to usual care. And one really interesting finding was that the top 3 messages all use the phrasing "reserved for you." A flu shot has been reserved for you. If you see the blue arrow that's third down from the top, that was the message that I designed with my collaborator. And then the blue arrow towards the bottom, that was the comparison condition that we designed. So I'll tell you about that comparison. Why would we think that reserved for you language might work? Well, it might sort of set a default, like this is the standard thing that's going to happen, or it might trigger loss aversion. This vaccine is mine and I don't want it to be taken away from me. Or maybe there's a sense of reciprocity. The doctor's office went to so much trouble to reserve a flu shot for me. I should reciprocate by actually showing up to get it. Or maybe it sort of signals that flu shots are a scarce resource and I'm one of the elite few that gets one. Patients got a series of 3 text messages the night before their doctor's appointment. The first one just said the date and time of their appointment. The second one was this photo of a flu vaccine vial. And in one condition, the reserved condition, we wrote "your flu dose" on the vial to try to get this this ownership thing going. But then the main difference between our 2 conditions, the reserved condition and the available condition, came in that third text message, where the reserved condition, they were told, "A flu shot has been reserved for you to receive at your appointment tomorrow. Reply Y if you want this shot held for you, and if you don't." And if they did reply Y, the response they got back was, "Your flu shot will be ready for you at your appointment." And then in the comparison condition, the available condition, they were just told flu shots are available at your appointment tomorrow. Reply and if you would like to receive one. If they did, a flu shot will be available at your appointment. So there were a little more than 3,000 patients per arm. The red and blue bars here are the reserved and available conditions. The black arm is the usual care condition that was used for the entire mega study. That wasn't specific to our sub-study. The reserved arm had a vaccination rate that was about 1.5 percentage points higher than the available condition, which was not statistically detectable difference with this sample size, although reserved was higher than usual care control. I'll just focus on the left-hand side of the graph. Since we started late, I'll skip through explaining the rest of the graph. A number of teams have looked at this reserved for you language. One of them is our own Sylvia Sarcardo here at CMU. At this point, we're really confident that the reserved for you language does increase vaccination behavior, and we're also really confident that it's a very small effect. It's like 1 to 2 percentage points. So by altering the wording of a message, you can move vaccination behavior around, but not by very much. One thing that we could do in this study was this mediation analysis, because we also measured whether people texted back Y. So getting the people who got the reserved message were more likely to text back Y than people who got the available condition. And texting back Y was an excellent indicator that the person was going to go on to get a flu shot. And so we saw this mediation or indirect relationship where the reserved message gets you more engaged with texting back. And once you've texted back, you're more likely to get vaccinated. Okay, so the reserved for you language worked modestly. During the pandemic, after this mega study came out, you saw a bunch of organizations using this language here and there. So it kind of got picked up by the media a bit. All right, let's move on. So let's look at the social processes category. So I'm going to focus specifically on social norms. Social norms are the things that we see other people doing or the expectations that other people have for our own behavior. And to illustrate that category, I'll tell you about the work by SDS graduate student Jose Arellano. Some of us in this room just heard him present this just a couple days ago at his second year paper presentation. So I'll give a brief synopsis here. So this was a study of parents that was conducted in an online survey. So we're just going to measure intentions here. We won't have measures of actual behavior. The control condition got this kind of very neutral message about children aged 6 months and older can receive a flu shot. And then there were two treatment conditions that conveyed a social norm. In this case, it was a consensus about what other people thought you should do. So one group was told that 97% of parents recommend children get vaccinated against influenza. And then the second treatment group was told 97% of medical doctors recommend that children get vaccinated against influenza. This was a true statistic, and then it came from a study of physicians who were also parents. So we either mentioned that they were physicians or mentioned that they were parents in the message. That message did influence participants' perceptions of what they thought, of what other people thought that they should do. So on the left, we asked participants, what percent of parents do you think, estimate the percent of parents that you think, estimate how many parents recommend vaccination or think that all children should get vaccinated. And the two blue dots over here, they're higher than the control conditions. So we did shift people's perceived norms. And then on the right, we asked what percent of physicians think children should get vaccinated. And those numbers are higher. People think physicians are more likely to recommend vaccination than parents. But again, the blue dots are higher than the red ones. So we did move people's perceived norms. The more interesting thing is, did we move their intentions to get vaccinated? So we gave this little scenario about, imagine you have a new child who's 6 months old. Would you get them a flu shot? They had to give a number between 0 and 100 to show how likely they would be to get this new child a flu shot. And they gave a higher number when they had gotten one of the norm messages than when they didn't. We did not, except for the most part, we didn't find differences between the parent norm and the physician norm condition. And for the sake of today's overview talk, I'll gloss over why we thought that comparison was of interest. Suffice it to say that communicating social information about what other people think that you should do moves, at least in this case, intentions by a bit. Okay, so what people think and feel, social processes, we can use those to move vaccination intentions or behavior a little bit. The literature indicates that the real power comes in this third category of intervening on behavior directly. So we're not going to try to change what people believe or their attitudes. We're just going to try to get them to change their behavior. And this is where the strongest effects tend to come up. So I'll give you two examples of this. This first one is an older study I did quite a ways back, where patients in an outpatient clinic got a letter in the mail. Some got a letter that said, flu shots are available and we have pre-scheduled you for an appointment on Thursday at 7:30 a.m. Here's how to cancel the appointment if you don't want it. And another group got a letter saying flu shots are available. If you'd like an appointment, here's how to schedule one. And then a third group didn't get any letter. And we could actually track through records of the clinic who actually got a flu shot, and the group in that pre-scheduled appointment condition, they were more likely to get a flu shot. They're the opt-out group there on the left. So we kind of like done one of the steps for them. They already had the appointment. They would have to like go out of their way to cancel it. And once you have the appointment, a lot of people tend to go to their appointments. Okay, so that's an example of just intervening on behavior directly. Then I'll give you a more current example. This is mandates. So requirements or mandates are probably the most strong-armed intervention that we could use to change vaccination behavior. So I'm not saying we should use them lightly, but they're also probably the most effective. In this study, also with Alison Buttenheim, the lead author was Alexandra Golos, who's a med student at Yale. We worked with a network of long-term care facilities. We did not get to do an experiment with them. We simply observed what happened when they instituted a mandate. So like most other networks of long-term care facilities, in the summer of 2021, they made an announcement that employees were required to get a COVID vaccine, and if they didn't by a particular date, then they would be terminated. So this graph shows, it follows what happened to people who were not vaccinated the day before the announcement. So everyone in this graph was currently employed but not yet vaccinated the day before they made the announcement. This dotted line right here, that's the July 31st announcement. And then we're going to follow them forward through time to see what happens to them. So yellow are active unvaccinated employees, which everyone is in the beginning, because that's what we defined this sample. And as we move along through time, a bunch of them become light blue. So they got vaccinated and remained employed at the organization. A few of them become dark blue. They got vaccinated, but then separated from the organization for some other reason. Some of them become dark red. So they didn't get vaccinated and separated from the organization. So at the time that they separated, they weren't yet vaccinated, but they weren't being terminated because they weren't vaccinated because the deadline hadn't hit yet. These vertical dotted lines here, those are the deadlines for vaccination. So clinical employees had to be vaccinated by October 31st, non-clinical had to be vaccinated by November 30th. And these light red sections that you see here, those are the folks who are getting terminated for non-compliance. So by the time we get to the right-hand side of the graph, there shouldn't be any yellow people left. There are a couple of yellow people left. I can't really explain that, but for the most part, everybody is either vaccinated or they're gone. Okay, so from an organizational standpoint, a mandate kind of works by definition, right? The goal of the organization is to have a vaccinated workforce. So they fire all the unvaccinated people. Hopefully they can hire new replacements who are vaccinated, and voila, they have a vaccinated workforce. But from a behavioral science or a public health standpoint, we would like it if the mandate actually convinced some people who wouldn't otherwise have gotten vaccinated to get vaccinated. Because that's going to increase the vaccination levels in the community. So that's what we try to do in this interrupted time series analysis. So we're going to follow the organization from before the announcement up to the announcement date, up until just shortly before they started terminating people for not getting vaccinated. And each data point here is a week. So for each week, we counted what's the vaccination coverage in the organization, what % of the employees have been vaccinated in that week. And that could change from week to week, both because more people were getting vaccinated and also because people were coming and going from the organization, because people quit and go elsewhere, new people get hired. What we're interested in was whether the slope would change at the announcement date here. So look at the red curve. You can see that it's slowly going up before the announcement date, and then it really accelerates afterwards, meaning that the rate at which people were getting vaccinated was steeper after the announcement. So this is just an observational study. There's no experimental manipulation here, but that pattern is consistent with the idea that the mandate announcement is convincing more people to get vaccinated. The different colors on the graph here correspond to different states. So this was a large network that had campuses in multiple different states, and there were different state environments for the different campuses. The red lines correspond to campuses where there was no state level mandate. So the only mandate that was influencing these employees was the organization's mandate. So that's kind of our purest look at how the mandate announcement had an effect. The blue aqua symbols those are states where there was a state level mandate for state employees at long-term care facilities to get vaccinated. So there was like a bit of a state requirement there for some long-term care employees, not these folks who were at a private organization. And then the yellow those were folks who were in states where the state required that all long-term care employees, regardless of who their employer was, get vaccinated. So in other words, even if the organization had made their announcement, the state mandate would have taken into effect and they would have had to do it anyway. So the blue, that explains why the blue and yellow, you don't see it as much of an uptick, as much of a change in slope. Some other interesting things to note, 3.7% of the workforce was terminated for non-vaccination. So that is a real cost, both to those employees and to the organization that had to replace them. So mandates are not to be taken lightly. This is not a causal experiment. But so I can't make claims about how effective the mandate announcement was. But if we look at the change in vaccination rate, it does look like there was a big change. Right before the announcement, 82% of the workforce was vaccinated. The day before they started terminating people for non-compliance, 95% of the workforce was vaccinated. So that's a 13 percentage point increase. Think back to that first study I talked about with the ownership language where we raised vaccination rates by 1.5 percentage points. 13 is bigger than 1.5. So this seems like maybe it's a big effect. So as I said, mandates are like one of the strongest things that we can do, but they also have real cost to them. Okay, so to summarize where we're at so far, messaging and social norm interventions, they can influence vaccination. They're probably going to be kind of modest in their effects. Intervening on behavioral directly, that's where we're going to get the biggest effects. That the literature is pretty consistent with that. Okay, I'm going to switch gears in a minute and tell you about a different sequence of experiments. It's a good place for me to ask if anybody wants to ask a question. Yeah, Duncan.
I mean, presumably getting people to vaccinate faster is also a desirable goal.
Mhm.
Did you do any analysis on like that, like the, I guess like the benefit into the of the fast this change like and how like the rate just in terms of not like the resulting number, but in terms of getting the immunization out more quickly?
I totally agree with you. Getting people vaccinated faster is a good public health goal because then they can't be spreading to others. I'm struggling with how we could address that in a way other than what we did. So this dashed line is, like the continuation of that slope. So if there hadn't been a mandate announcement, that's how fast vaccination would have been rising,
Right.
hypothetically. And then it was rising faster than that. So we're getting more people vaccinated, like more and faster seem to go hand in hand.
I guess, right, I guess like, I didn't perhaps it's impossible. If you could sort of decompose the difference between someone who's going to get vaccinated anyway, but you made them do it more quickly. Versus
Yeah. If we had a proper control group, like go back to my ancient default experiment. There was a proper control group that got no letter or got the opt-in letter. So we can not only look at who was back, like we got the electronic records, I think in March, because anybody who's going to be vaccinated is going to have done so by March. And we just counted up the number of people who got vaccinated. But we also had the dates when they got vaccinated, right? So it could have been that there was no difference in the total number of people who got vaccinated, but in the opt-out letter group, they got vaccinated in October rather than February. So like we didn't find that, but we had the opportunity to look for that in that kind of study. And if we had, I guess we would have been like sort of happy, like we didn't change the total rate, but we got them there faster. All right, yeah, Norm.
Yeah, quick question. So it seems like when you saw the difference in effect from like messaging, right? The 2%, right?
Mm-hmm.
That's kind of like a low bar for somebody to like change their opinion, right? So it's like, oh, they said like it's reserved for me, so okay, I wasn't gonna get it, but maybe so that 30 people or whatever, right?
Mhm.
But with mandates, right? And we were seeing like 13%. So I would think there was like a bigger hump for those people to get over. And so, like, I know the point of your research is not like, necessarily tied into ethics, but like, wouldn't those people then kind of like be unhappy potentially about like, yeah, I have to do this, but it's like being forced on me. So I'm just wondering, like, do you talk with folks like in the, like, do you have plans to like interact with the ethics folks and think about this, or just kind of wondering what your thoughts are on that? Because it seems like
Mm-hmm.
it's at the end of the day, like those 2% with the messaging, it was like, yeah, not a big deal, right? But then like that 13%, probably after the fact, they're like, man, I got strong armed into this and I'm not
Yeah,
happy
for
about it."
sure. I mean, this
It's a
was,
different question.
this was an observational study. We just got the employee
Yeah.
data set. We didn't have the opportunity or the permission to talk with any of the employees. Just from talking to folks here at CMU, we had a mandate for COVID vaccine. I know of people who did it so they could keep their job, but they weren't happy about it.
Mhm.
So what are the consequences of that? Well, maybe some of those employees are a little bit more disgruntled with their employer and a little bit less likely to like put forth their full effort for their job. Maybe they're a little bit more willing to look for outside options in employment. So yeah, there are costs to the organization. In terms of ethics, I mean, there are lots of situations where we force behaviors on people, like, you have to wear a seatbelt when you drive, otherwise you're gonna get ticketed. That was very controversial when it was first introduced. Kids have to get vaccinated to register for public school. I mean, there are waivers, but those aren't without controversy either. So I don't know that I would put COVID workplace vaccination requirements in a whole other category from other regulations that we already have. But absolutely, if you start regulating every single part of life, then we're living in a draconian dictatorship and nobody wants that. So you got to be really careful when you're gonna pull out these big guns.
Yeah, the cost to the organization is an interesting point. But I was just thinking, like, we had somebody who was sitting over here when I think Hoda gave her talk that asked about, well, if I want to smoke, like, and it's going to kill me, like, ethics says that I should be able to do that, right? So it's just kind of an interesting.
There are smoke-free workplace rules. University of Pennsylvania Medical Center actually has a rule, or at least they did. I don't know if it's still current. That you cannot be employed if you are a smoker. It's not even just that you can smoke at home. If you are a smoker, they will not hire you. And if you're already hired, you've got a year to quit, and otherwise you're out. So yes, there are some workplace rules that do seem pretty strong.
There's actually some movement to make smoking illegal for certain cohorts of people in the future.
Yes, I was just hearing a news story about that, and I can't remember where it was, but there's
New Zealand, right?
in New Zealand.
Yeah.
Okay, so
That sounds very.
so people born after a certain date will never be able to buy cigarettes.
That's the proposal that we heard of.
Yeah, no, I mean, it's a very rich discussion topic of what should we regulate and what shouldn't we regulate. Okay, I'm gonna take this lull in the conversation as an opportunity to move on to the sort of second section of my talk. So here I'm gonna talk about how lay people understand the concept of vaccine efficacy. So this is work that I've done with MD PhD student Allie Butler. She just completed her 8-year MD PhD program, is about to go off to residency at UCLA. And we were interested in this question. How do lay people think about this? If I tell you the COVID vaccine is 95% effective, what does that mean? How would you describe that? I think you're going to say the right answer. All right, go ahead. No one else is brave.
Well, now I feel like if I get the wrong answer, it's bad. And then I guess I was thinking like if counterfactually, it's 95%, like people who would have gotten the vaccine don't get it 95% of the time.
So if you would have gotten,
I
if you
guess
would have
that's
got,
probably,
if
I guess that's probably not what it means actually, now, but that would be like maybe that's the lay interpretation, but.
The lay interpretation would be, yeah, that's a 5% chance I'm getting COVID if I get.
yes, and that is what a lot of people say in our survey. So that's what this graphic is supposed to be. So it's 95% effective, 95% of people are protected. The other what happens to the other 5% of people? They get sick. Which is a little crazy because 5% infection rate for COVID is pretty high because it kind of depends on the time frame and the situation and stuff. But also it's easy to calculate, right? I mean, your risk should be low after you've been vaccinated. 5% is pretty low. If it was 98% effective, you would have said only 2% of people get sick. That you would have that logical relationship. So it's kind of a reasonable answer in a lot of ways. but it doesn't capture the normative concept of relative risk reduction, which is what Duncan was describing. It's the amount of risk reduction that you get from vaccinating compared to not vaccinating. So like imagine a placebo group and a vaccination group. Let's say 20 out of 100 placebo people get sick. We're going to take away 95% of that risk. So we're down to only 1 out of 100 people getting vaccinated. That's a 95% efficacy rate. We've reduced the risk by 95%. But I hope you can see that this is like a little bit of a nuanced, complex numerical concept that not every layperson would instantly think of. So we were interested in how lay people thought about this. So we designed some questions. They were these cute little alien vaccine trials that Allie came up with, aliens so that they wouldn't have any real world beliefs that they would apply to this. And we asked them 2 kinds of questions. One of them was the efficacy question. The efficacy question, we're going to tell you about what happened to the placebo aliens and what happened to the vaccine aliens, and you're going to tell us how effective the vaccine is. So in this example, we've got 10,000 placebo aliens, 500 of them got sick, and another 10,000 vaccinated aliens, and 200 of them got sick. You should be telling me that the vaccine is 60% effective because we got rid of 60% of the risk. From 500 down to 200 is a 60% reduction. But if you're doing what we're called the lure response, you'd totally ignore the placebo group and you'd say, 10,000 aliens in the vaccinated group, 2% of them got sick. I guess the vaccine is 98% effective because 98% of them didn't get sick, and that's what you would write down. The other kind of question we used was the illness question. So here we're going to tell you how effective the vaccine is, and you're going to tell us how many aliens got sick. So let's say we've got a placebo group of 10,000 aliens, 1,000 of them get sick. We've got a vaccinated group of 10,000 aliens, and we want to know how many of them got sick. The vaccine is 60% effective. If you're following along, you should say 400 of them got sick because 400 is a 60% reduction from 1,000. But if you were following this lure response, then you would say, oh, well, 60% of them won't get sick and the other 40% of them will. So 4,000 of them will get sick, which in this example is like kind of a crazy answer, right? Because it means like way more vaccinated aliens got sick than placebo aliens. But that's the whole point of the lure response is you don't even think about the placebo group and that you're supposed to compare them. So we made up a whole bunch of these questions with different numbers, and we constructed them in such a way that across there were 8 alien vaccines we asked about. Across that set of stimuli, the normative correct answers were completely uncorrelated with the lure answer. So you could be influenced by the normative answer or the lure answer or both or neither, and we could dissect all of that. So here's one of our graphs. So on the x-axis, we've got the participants' efficacy rating. We asked them how effective is the vaccine. They said, 72% or whatever, and that's the number there. And then on the x-axis here is 4 different levels of the normative value, what the right answer is. So if participants are doing something like vaguely correct, we should get a positive slope here, which we have. So they're not like exactly hitting the number right. Like when the right answer is 90, they're not saying 90, they're saying like 72, but they're saying higher numbers for vaccines that really are more effective than for vaccines that aren't effective. The different colors are the different lure answers. So there were 2 different vaccines that were really 60% effective, but had lure answers that if you were following the lure, you'd say 96 or 98. So we'd see a separation from these colors if people were following the lure, and they're not doing that here. They're showing a nice normative pattern. They're not falling for the lure. Okay, then let's take a look at the illness questions. This is the one where we tell you how effective the vaccine is, and you tell us how many aliens got sick. So again, here's the participants' ratings, now the number of illnesses, and again, different levels of normative value. But here you see this color separation, right? They're giving higher answers when the lure is high than when it's low. So this is the lure pattern. They're also showing a bit of a positive slope here, so they're paying some attention to the normative value, but they're also being influenced by the lure quite a bit. So this kind of non-normative reasoning is especially coming out with this version of the question, not the efficacy version of the question. I'm not showing you these in the graphs, but we also measured participants' numeracy, which is a standard scale of like how good they are with numbers, like translating decimals to percentages and stuff like that. And the people who are higher in numeracy, they showed more normative patterns in these questions. Okay, so then we thought, like, well, maybe people just don't know what vaccine efficacy is. Let's just tell them. So we developed a simple tutorial to explain the concept of vaccine efficacy. We had these little pictographs showing them the comparison between the placebo group and the vaccinated group. We gave them the formula. So it was like kind of a number heavy tutorial. And we gave that to half the participants in the next experiment. The other half got kind of like a fake tutorial. It had pictures of aliens and stuff, but it had nothing to do with vaccine efficacy. Okay, so let's see what happened there. So top, we've got the efficacy questions. Bottom, we've got the illness questions. On the left, we've got the control group. On the right, we've got the subjects who got the tutorial. So let's look up top here in the control group. Again, we've got a positive slope here and no separation between colors. So that's our normative pattern. But those who got the tutorial, they have an even steeper slope. So these guys were doing kind of the normative thing. These guys are doing an even more normative thing, tracking the normative values better. And neither one of them is falling for the lure. You don't see the color separation. Down here, the illness questions, this is the control group. We've got this color separation. That's the lure pattern that we saw before. That gets shrunk quite a bit when you get the tutorial. So the tutorial helps people be more normative in the efficacy questions and use the lure less in the illness questions. I'm not showing it to you in these graphs, but again, we measured numeracy, and we saw that higher numeracy people were more normative and used the lure less. But we also found that the high numeracy people benefited from the tutorial more. So like the improvement from control to the tutorial, that was bigger in the high numeracy people. So it's kind of like a rich getting richer kind of situation. Like the high numeracy people were already pretty good, and now we're making them even better with the tutorial. And those poor low numeracy people, like they're not getting much benefit. Yeah, nothing.
And then efficacy question, do you know the people who are, because presumably the lures and what's you mentioned about, do you know what the people who are getting it wrong or are doing? Like what wrong answers are they putting?
We do have some breakdown of that in the paper. I didn't bring those graphs. So we categorize people are like giving the exact normative answer, like not just a positive slope, but like really if it's 92%, they really wrote down 92%, or did they give the exact lure answer? Or did they do something else? Those are the three main categories. There's something else. There's small categories of people doing like the complement of efficacy. Like if the vaccine is 60% effective, meaning it reduces the risk by 60%, they'll write down 40% saying like, oh, the vaccinated group had 40% the level of illnesses as the placebo group, which is true, but you're supposed to, that's not the efficacy. That's the converse of the efficacy. So that's sort of forgetting to subtract from one. That's a somewhat common response. Okay, so I'm going to tell you about one final experiment. In this experiment, the goal we gave ourselves was to design a tutorial that would help the low numeracy people. So we came up with two tutorials, one that didn't use numbers at all and one that did use numbers. So the right-hand side, this is our conceptual tutorial that doesn't use any numbers. It just talks about comparison between the two groups. So like a very effective vaccine reduces the risk of getting sick a lot. You know, it's like placebo group reduced down to a lot in the vaccinated group. Somewhat effective vaccine reduces it a little bit. And there was a third example of not effective at all. In the quantitative tutorial, we tried to have like the same general layout with like still the boxes and stuff, but we had numbers and we gave them the actual formula and showed them how to compute efficacy. So participants got one of these tutorials, or they got the control condition with the fake tutorial that's not about vaccine efficacy at all. Another thing we did was we changed up how we were presenting the problems to participants. So in this study, participants compared two vaccines side by side. So here we've got the Eon Lilly vaccine that has 10,000 aliens in the placebo group, 500 of them get sick. 10,000 in the vaccine group, 200 of them get sick. You're supposed to tell us how effective it is. And then right next to it, we've got the Galactic Space Cluster vaccine. It has 10,000 aliens in the placebo group, 4,000 of them get sick, 10,000 in the vaccine group, and 800 of them get sick. And you're supposed to tell us how effective that is. So half the participants had to put in actual numbers here. The other half of the participants just had to tell us which vaccine is more effective. And that's why we went to this, this type of item, was we wanted a situation where you didn't have to use any numbers at all to give your answer. All you had to say was like, that seems like a pretty big reduction. That seems like a smaller reduction. I'm going to pick Y is more effective. I have no idea how to compute the actual number. It just kind of seems bigger to me. So our prediction had been that the low numeracy people would do particularly well if they got the conceptual tutorial and they got the response mode where they just had to make a choice. They didn't have to put in any numbers. The other half of the participants did have to put in numbers, but for purposes of our analysis, we just compared the two numbers to compute the one that they chose so that we could analyze everybody the same. And then in this question, you're thinking about efficacy. There were also questions where the number of sick aliens in the vaccinated group, that's what you were either computing or saying which one was bigger. Okay, so because, oh, sorry, let me just say one more thing. The way the two vaccines that were side by side were selected were always such that the normative formula would tell you to pick Y, but the Lure formula would tell you to pick X. You know, like this is an 80% reduction. This actually is more effective than this, but 200 is smaller than 800. So if you're just looking at these numbers, you would pick X. So every item you either get right or wrong, where right is you did the normative thing and wrong is you did the Lure thing. So that's why on the y-axis here is the number you got correct. There were 9 problems. So the red bars are the control condition. The yellow bars are the quantitative tutorial. The blue bars are the conceptual tutorial. We've got illness task here on the left, efficacy task here on the right, and then numeric response and choice response. Both tutorials do better than the control, but the quantitative tutorial always does the best. So, you know, we thought that like, especially for low numeracy people, with, you know, in the choice response, the conceptual tutorial would do best. That was not true. Again, I'm not graphing the numeracy levels here in the graph, but it was true that the quantitative tutorial did better than the conceptual tutorial for high numeracy people, and it also did better for the low numeracy people. And the high numeracy people had the bigger benefit from the tutorial, regardless of what kind of tutorial it was. So we designed 2 like kind of effective tutorials, but we failed in our mission to find a tutorial that would be specifically beneficial to low numeracy participants. Okay, I'm going to wrap up here because it's 1 minute before 4. So we saw this Lure pattern, especially in the illness questions. High numeracy people were more normative. The tutorial worked. It decreased the Lure pattern and increased the normative pattern, but it helped the high numeracy people the most. And even the conceptual tutorial helped the high numeracy people the most. Yeah, Russell.
So some people may know what the efficiency means, maybe after you say efficacy means maybe after you give them the tutorial, they still might be reluctant to use it. So if you told them this vaccine is 99% efficacy, but I know somebody who took the vaccine and got sick, like, but they just say, oh, but I know this person, so forget that abstract number. So
I mean,
do you think that this would affect their willingness to use the number?
Oh, that's an interesting thought. I mean, the purpose of the whole alien setup was to try to get around that, but did we really get around it? We don't know. We did ask for participants' own COVID vaccination status, and that was not related to anything. It didn't moderate anything. Of course, there weren't that many unvaccinated participants, so maybe we're low in power. But I guess if what you're saying is correct, I might have thought that the tutorials would be less effective for people who themselves weren't vaccinated, if that was a sort of a measure of their vaccine skepticism. But again, we're probably underpowered to see that. Do you have any other thoughts on how you would look for that?
I mean, it's a different DB that I'm interested in. I'm interested in like if you had two, like, if you had conflicting efficacy information and like anecdotal information, would you make the choice consistent with the efficacy information or the consistent with the anecdotal information?
Oh, I see. So it'd be a different experiment
Yeah.
where we present anecdotes that conflict or don't conflict with the trial data.
Yeah,
And then,
like would
The
the tutorial affect willingness to rely on the efficacy information?
I see. That's a pretty good idea.
Kind of sounds like Dan's. concept. It's like, right, it's like, it's, I mean, it's not with vaccines, but it's like you give them numerical information about the restaurant, you give them anecdotal information about the restaurant, sometimes they conflict. How does that affect their, I mean, there's also the memory part.
Yeah.
Yeah, I mean, there is well, as we were just talking about the other night at class, Duncan, there is this long storied history of literature on using statistics versus using anecdotes in reasoning. So this could be a nice extension of it. Yeah, Nick.
I have a question about just the earlier result that like the people were more normative with the and less sort of sensitive to the words for the efficacy questions,
Mhm.
not for the illness questions. So people are generally pretty good at estimating efficacy, but not good at, I guess, extrapolating from data to make predictions about actual behavior. Right? That's sort of a way of expressing that. Or in other words, like the illness question is harder than the efficacy.
I would definitely say the illness question is harder.
Yeah.
I mean, to be honest, I did not predict that before we started running pilot studies.
Yeah.
And it's a little hard for me to explain why it's harder. The way Ali explains it, which I think I agree with, is that the efficacy question is sort of structured in a way that encourages you to make a comparison. We tell you about the placebo group, we tell you about the vaccinated group, and then we ask for the efficacy. And there's sort of like an affordance in the question that you should be comparing those. The illness question asks you about the vaccinated group. How many vaccinated aliens got sick? So there's no hint in the question that you're supposed to be comparing to the placebo group. So you could look just at the efficacy group and at the vaccinated group and think that you're doing the right thing.
Thanks.
Yeah, Joey.
I feel like the difference between the tutorial, people who were tutored, I guess, in the illness group is kind of like, they're like massively over, like estimating, right, because of the lure. And then when they're correcting downwards, right, towards the, yeah, exactly. It's like going from like really high off.
Yes, that's right. Yeah, that's
Yeah.
true. They're giving numbers that are way too high, because of the lure. The lure numbers are like 4,000, 2,000, so they're giving numbers like that. And with the tutorial, they give less of those wildly, inappropriately high answers.
Yeah. I was curious about like if you guys flipped it, so if you were asking people like, how many people would be healthy, I guess, then if you know what I mean? Like,
Oh, how many people will stay healthy?
stay healthy, then it would be the opposite, right? You would have people, I guess. Yeah, underestimating the correct number if they were to follow the board,
Mhm.
right? The people who
Mhm.
get sick. Yeah, just like as a thought.
The number who stay healthy is always going to be a bigger,
Yeah,
now it doesn't have to be a bigger number, but we
right.
always had the base rate of the vaccine be less than 50% because otherwise it's just too wildly unrealistic. And people are worse at dealing with big numbers, so
Yeah.
you might get more noise that way. But I think you're right that the overestimation would turn to underestimation.
Right, and it's just very interesting because if you're actually, because you mentioned that like actually the in real life, I guess vaccines are quite effective, right? So I guess like, if you were to try to apply this, like actually in the populace, the numbers you come up with would start to get like a little bit hard to convey, right? If you were to be like, if all the people in the US got vaccinated, right? It'd be some really weird numbers that people have to try to process.
Yeah, like if you look at the original clinical trial for the first mRNA COVID vaccine, 1% of the placebo group got infected and 0.05% of the vaccinated group, and that's how you got your 95% efficacy, but like they're really small
Yeah,
numbers.
yeah.
Yeah, we were trying to go for like round, pretty easy to process
Or,
numbers,
yeah, for the.
but it would even get worse if you went more realistic that way.
Do you think the people who answer the efficacy question could answer another an illness question with a different placebo group more accurately than people who answer the illness question by itself?
Wait, say that, say that.
So like there, no, it's, my thinking is like answering the efficacy question, like made people do causal reasoning. And they inferred, like, they had to infer the efficacy, right? As opposed to illness people who just got the efficacy.
Oh, yeah, we actually did, in the first study, it was within subject, and then everybody got a block of efficacy questions and then a block of illness questions, or vice versa.
Oh.
So we counterbalanced the order, and we did get this order effect, that if you got the easier efficacy questions first, you did better on the illness questions than if the illness questions were the first thing that you were seeing. The idea being that the efficacy question prompts you that there's a comparison that you're supposed to be making, and then you remember that
And
when you
then
get to the illness question.
yeah, okay.
Yeah.
Cool. That's, thank you.
Yeah,
In my experience, people are very visual and visuals help them understand, and some of your slides had nice boxes that showed the visual, yeah, this one. Did you find, whereas the other tutorial that just had text and a chart on it with numbers and words?
I mean, it did have a pictograph of alien
this one.
heads, but
Yeah. Oh, there's another one. This one.
no, this is the only other tutorial.
Okay, the rest was a report. So, but do you find that the visuals make a big impact in how you present these tutorials?
They might. Before we ran this first tutorial study, we ran a pilot study that had this pictorial tutorial or the pictorial control group, or a purely numerical tutorial and a purely numerical control group. And it seemed like we were getting a better effect with the pictorial one, so that's the one that we used for the later study. All right, it's already after 4, y'all, so I'm gonna go.
Paul Lehner had a quick comment here. He dropped off. He said, just a thought before I sign off. The same types of introduction displays tutorials would be relevant to AI explanatory capability. Example being AI system recommends a treatment for an individual patient predicting 9% efficacy for proposed treatment. How does one explain that? Same way, just now applied to individuals versus populations. Just a thought.
Yeah, that is a good idea. All right, everybody,
Let's-
thanks for sticking with me late into the Friday afternoon.
Thank our speaker again. Thank you, Gretchen.
That's the answer. No one's gonna notice if you take a lot of cookies with you.